Well, thank you, ladies and gentlemen, for joining us today for this Zoom video conference session. I still see people are coming in, but we'll move ahead. I'll admit them as they come. My name is Drew Ferguson, Public Media Relations Coordinator for the Grey Bruce Health Unit, and I'll be your moderator for this session. Joining us from Public Health are the Medical Officer of Health, Dr. Ian Ara, and Environmental Program Manager Andrew Barton, who may be able to take some more specific questions with respect to environmental issues. Following my introduction, the format of the meeting will begin with opening remarks from Dr. Ara, about 10 to 15, 20 minutes or so, who provide some additional context with respect to the Stage 3 opening as it pertains to the upper tier and municipal sectors. And from there, we'll address the many questions we've received. I've tried to group them in various themes and of a general nature. If you wish, you can add questions using the chat function on the Zoom screen. If time does not permit all your questions to be answered, please forward them to Public Health through our Contact Us page on our website, and we will respond to all inquiries. Would also apply to any questions you have related to your own specific circumstances. The email is publichealth@publichealthgraybruce.on.ca. And please note, this session is being recorded and will be available on the Grey Bruce Health Unit YouTube channel. A link will be provided as soon as that becomes available. So to get underway and take us through Stage 3 opening in Grey Bruce, it is my pleasure to introduce Grey Bruce Medical Officer of Health, Dr. Ian Ara.
Thank you, Drew. Thank you all for your attendance and engagement. I just want to start by thanking everybody for the great results that we have in Grey Bruce. It's directly related to your effort as individual or as a leader in your organization. The ability to continue to maintain zero deaths in Grey Bruce is not a coincidence. It's not a simple thing that we can just look at that and move on. It is an impressive result, and when you compare it to the expectations or the modeling of what would have happened if we didn't have all the measures in place and the engagement from the public, it would have been totally different. So for that, I want to thank you. And going into the presentation, I have a group of slides, around 20 slides, and I'll go through them. They would probably have content that would answer many of the questions that we have been receiving and expecting to receive with the reopening stages. And again, like Drew mentioned, we will do our best to answer as many questions as we can. Drew, I'm trying to share my screen. Please let me know when you see it. Can you see my screen, Drew?
It's there now.
Okay. Just want to try to move it to where I can see and at the same time read. And so opening Grey Bruce, presenter disclosure, I have no potential conflict of interest, whether it's through grants with the government or through the private sector. And the objective of this talk, as I mentioned, better understanding of the process of safe reopening and trying to address questions. So what does safe reopening look like? What does it mean? And what are the principles to it? Many people know that we try to minimize deaths and mortality from COVID, and that's what we did in the mitigation period, April and March. And we continue to work on, however, in the reopening, there is another principle, which is minimizing disease and mortality from measures to respond to COVID. And we get these calls sometimes, are you aware that there's mental illness? Are you aware that this is gonna do this? We're definitely aware of it, and this is actually core to the reopening. And to balance these two objectives until we have the herd immunity, the silver bullet that we're all aiming for, we need to have a balanced approach to minimize these measures against COVID, disease, and death. And it's not only mental health, there is the domestic violence, something that happens in pandemics if you lock things in and continue for a longer time. Heat waves is another reality that we deal with every summer. And the sooner we're able to reopen and have cooling centers for the people who are less affluent of us, more chances we're going to minimize deaths and disease. Societal disruption could be an eventuality if things didn't go well, and luckily we have not even got close to that. Economic impact. Economy is the #1 determinant of health, no question. And the longer you shut down the measures during the mitigation, the higher the impact on health will be. And that's why we need to open as fast as we can, as long as it's safe. So with these things in mind, we'll go to lessons learned from different parts of the world. Countries in Asia have control measures similar to the one we implemented. They have different societal norms and with dictatorships, the ability to actually implement the measures so robust that they would have control over the outbreak. And as soon as they went into reopening, again, there is a potential for research anytime there is introduction of the disease in the community. And they have been managing very well. And when I started by saying we have an extreme success here in Grey Bruce, the fact that we did not really use, and we cannot use, it's not part of our social norm to have the extreme measures that could be used in some of these countries. We managed the control over the outbreak through education, through providing information to the public. The public has been concerned, engaged, but not afraid. And that's where the importance of the work that everybody around the table had. And it's not just public health or the healthcare system, rather it's the different levels from government, first responders, and again, the many companies that donated masks and did implement all the measures that we asked them to implement to have the safe reopening that we have. If we go to other lessons, different lessons from Europe, Sweden went to the approach of let it burn through and we'll get to the herd immunity. And it burned through, but the herd immunity that was reached in Sweden was about 7%. That's an older number, but that's where the first results of that approach came out, where they had only 7%, far from the 70% required number for herd immunity, but they had more cases and death, way more than the 3 other Scandinavian countries combined that followed the same measures that were implemented in Ontario.
Dr. Ara, I'm going to interrupt if I may. I don't think your slides are advancing.
Thank you. I should have. Thank you for this.
They're moving now, yeah.
Let me share it again. I'm not sure which screen was shared, Drew.
It only stayed on the home screen. It didn't go beyond the first screen. Yeah, that was the one we saw.
I'll just go zoom through them again. The disclosure, the objectives, as I mentioned, what safe reopening is. These are the 2 goals: disease mortality from COVID, disease mortality from measures against COVID. And this is a list of these measures. And again, these slides and the recording will be available for the group to review down the road. Lessons from Asia, it was verbally, most of what I said included in this slide. In Europe, Sweden went into, let's not have all the measures of social distancing and the lock-in or the shutdown that we had. The United States, it goes without saying, most people are aware of what's going on. And although they had the same scientific advice that we have, the implementation of it has not been there. And the engagement from the Republic about the importance of different measures has not been there. So herd immunity, that's the silver bullet we're looking for. It can be achieved through different measures. Vaccine is the one the one solution that would be a game changer. Measles back in the day was as scary as COVID, and now most healthcare providers don't see a measles case in their practice in their entire career. And that's because of the vaccine. Phased lifting of restrictions, that's what we have in the province. Gradual lifting and observing what happens and moving from stage to another stage in a safe way. Dynamic physical distancing, a nifty idea, but probably is not practical, not for the economy, not for the control of the disease. More or less, it is to shut everything down for 2-3 months, then open it up for 3 or 4 months. Again, theoretically, it might work. Practically, it does not. Uncontrolled outbreak, that's what Sweden experience was. Hammer and dance, it's an approach, again, similar to dynamic physical distancing, to shut it down for 6-7 months, and it's going to be gone away by that time. Again, there is no real evidence that this would be the case. Just trying to make this bigger. I don't know if people can read through it. However, there are 3 sets of indicators we look at when we planned reopening, and these slides were generated before the reopening started and have proven to be consistent with what the ministry put forward, just because we use the same scientific source, which is the same source. It's the science and the public health recommendation. There are indicators about virus spread, about system capacity, whether it's hospital capacity or public health measures, case management, contact management, the ability to trace contacts, and testing capacity. And when you put all these things and measure them through stages, the plan would be to go through 3 stages. And as we all know now, the stage 1 has been successful, similar to stage 2, and we are in stage 3, and we continue to be successful. Stage 3 is the one that has the highest risk. The activities in it would engage a high number of people and more activities that have high risk of transmission. And we measure this risk based on sets of indicators or sets of principles. And these are the same principles that you would apply in your workplace, in your workplace plan, in your personal life. They would minimize the risk. The first one is the number of people in any activity. The higher the number, the more chances there are of transmission. The longer the time of interaction among people, and the ability to modify the environment around people engaged in the activity. To put it in concrete, in a concrete example, if you look at golf courses, golfing was one of the first activities to open in the first stage, because there is a very small number of people and the amount of space available for the activity. The interaction among them could be minimal. If they are face-to-face, it could be minimized to nothing. And the ability to modify is tremendous. And that's what makes it a low-risk activity and opened earlier. At the same time, if you go to the other side of the spectrum, opening bars and movie theaters, it's a large number of people in a limited amount of space. There is a longer duration of interaction, and the ability to modify it's not there. It's the amount of space, and the activity itself dictates that people would be together. And in a situation of a bar, you're finding people who are talking over loud music, so that's similar in risk to coughing. Singing as risky as coughing as well. And the added layer of alcohol would probably reduce the ability to people to be mindful of their surrounding and reduce the risk for themselves and others. If you observe your environment in any situation you're in and apply these principles, you will be able to successfully continue to have lower risk for yourself, your family, and the community. And early in April, before even there was opening, our reopening plan was put in place, and this is an example of a couple of activities to prepare these sectors to hit the ground running when we get the green light from the province. And now we have the luxury of looking back and seeing that we actually have been very successful in predicting the activities in which stage and what level of risk required. Again, the decision is provincial, and the local health unit would help in interpreting the direction for the orders related to the emergency. We always have the authority to restrict further, but we don't have the authority to override this. And this was a major question all along, that how come I'm not in the first stage? How come my business is not in the first stage? And this would continue going forward. The next big thing is school reopening, which would probably have some effect on the dynamic on the outbreak in the community, not just within the school. And these things are to be learned. Some of these things are unknown. We will continue to have the measures in place and measure the risk with different age group, with different activities within the schools, and any other activity that would be entailed in reopening schools, whether it's daycare and other. Implementation, as you know, the stages will proceed based on 3 to 4 weeks, and that's not a random number. It's based on the incubation period of 2 weeks for the disease. So any measure we put in today, any activity we open, and concretely, if we look at schools opening in the first week of September, we need to wait for 3 to 4 weeks, because if there is any transmission of the virus, it's going to take 2 weeks for it to surface and a couple of days for testing coming back. And we will continue to monitor these things. So if there is an uptick in the cases, significant enough research, we might retreat to previous phase. It has not happened so far. And if we do the right thing, and by we, I mean the collective we, the societal we don't have to do this. If we're not sure there's an uptick, but it's not strong enough, we can lengthen the phase. And if there isn't, we continue to the next phase. Now we are in the third phase, and this is the modified reality that we're gonna live with, the modified normality. This is as good as it gets until we get the vaccine. There was a question about vaccine and, is it in sight? I'm cautiously optimistic, and I've been saying these words since April, that by the end of the year or early next year, we'll have a vaccine that is safe and effective. There are news about a vaccine from Russia, I believe, last week coming out that it's going to be distributed in September. We haven't seen the data to ensure safety and efficacy. However, if you look at the candidate vaccines developed in different European and North American countries, mainly the United States, it is very promising to see that there will be a vaccine by the end of the year. And usually it takes 3 to 6 months for distribution, on mass distribution for the public. So that would be the silver bullet we're looking for. Until then, the role of the health unit is to support the different partners, different organizations and the public with multiple initiatives or multiple roles that are essential to the management of the emergency. The last one, communication, is probably was one of the most powerful ones, just because the dynamic of the outbreak and the control of it is in the hand of the public. And if the public is informed, engaged, provided with the information to make the right decision at the right time, that will make all the difference. We will continue the contact management and tracing, which is, again, essential role, and it's very complex. It's not as simple as you would think. It's just a phone call, and actually we're in the process of issuing a media release just to provide the different aspects of this activity and how it nips it in the bud before it becomes an outbreak that's not controllable. And we will continue to lead and collaborate with healthcare partners and other part of the system. So 2 more slides practically about your organization, about your personal life, if you want to apply these things. So the hierarchy of evidence in control of the transmission looks like this: an upside pyramid where the wider base is physical distancing. It is king. This is what reduces transmission. And there is nothing magical about the 2 meters. The furthest you go from a person, the bigger the distance is, the less the risk of the transmission. World Health Organization recommends more than 1 meter. And that's, based on recommendation to the whole world. In North America, we have we tend to have more space to anything we do. And that's why the 2 meters is doable, feasible in our environment. Engineering controls are also effective, but less effective than physical distancing. However, they are actually effective. One example is having a shield at the front desk in a public area, or any engineering solution to reducing risk. Administrative controls, which is the policies that you would have to cleaning. For example, cleaning happens at night, not during the day, to reduce the risk of people being in the same space. PPEs, wearing a mask is the least effective of all. However, it is very effective from the point of view it's easy to implement, easy to carry, easy to utilize. And we've seen with the order in place, even without any enforcement, that the public has been doing the right thing. There's the numbers that come to us and assessment from different partners describes an optimal situation in Grey Bruce, even without enforcement. It is important, it's of critical importance that not one of these things would do the trick, rather the addition of benefit with each one of them. PPEs is not going to be a replacement for the rest, rather an added benefit, augmentation to the rest. And you can implement these things in your workplace, in your life, in different situations, same principles. The final slide is what happens if there is a case in your workplace. Most people have a lot of anxiety about COVID, rightly so. However, anxiety really should be based on risk. So if there is no risk to a person, there shouldn't be anxiety. There should be concern, as always, but not anxiety. By the time a person is diagnosed in your workplace, means their test went to the lab and the result came back after 3-4 days. That means that person has not been in the workplace for 4 days. There's no need to panic and start cleaning everything in the workplace. It's actually futile to clean it after the fact, because the virus will not survive more than 24 hours. The latest numbers early in the outbreak was conservative as 48 hours. Now we know that 24 hours is actually more than sufficient. So by the time you heard about it from your colleagues, that means it has been already destroyed. The virus that's in the workplace destroyed since the person left the workplace after getting sick and getting tested. By definition, the health unit knows about it because we received the first result. The law in Ontario would say any communicable disease result would go from the lab. Every lab has to report to the MOH where the person resides, and we contacted the person. So by the time that person contacted their employer, we already dealt with it. It's already complete. We usually complete this outbreak management in the workplace within hours. And for reassurance, these numbers are a bit old from the slide. It's 122 or 123 today. With each case, there is a workplace related to it where the person worked, and some people work in more than one workplace. Universally, we've been able to have zero transmission to co-workers. We get on it really quick, within minutes, within hours maximum. The target is within 24 hours, 90% of the cases. We still maintain the 100% of the cases within 24 hours, and most of them actually within 2-3 hours. We contact people, we evaluate the risk, and we evaluate who was in their contact as close contact to them. And we call these people to evaluate the risk and direct them to do what they need to do, whether it's isolation, testing, or monitoring symptoms. If you heard of a case in your workplace and you did not receive a call from public health on that day, rest assured, there's no enough risk for you to be called. So that will be a really good day if you don't get a phone call from us. Simply put, there is no need to go do mass testing. And we've seen a couple employers at some point where they shut down the facility to do deep cleaning. And for the life of me, I don't know what deep cleaning means. The virus is not hardy. It's very easy to destroy with any soap or house-used bleach. So by the time that those people shut down the workplace, there's enough anxiety in the community to go to assessment center or to say, I have eaten in that restaurant, should I be tested or not? And our phone lines will light up. there is no need for that anxiety. We already got this. By the time you heard about it, again, we already heard about it. And the parting word with this slide is, if you did not get a phone call from public health, that is a really good day. Your risk is not there. If you spend a couple minutes on our website a day, it will be useful. There is new material every day, and it is relevant to the situation at hand. This is, again, information for organizations. If you're in a management position and you want to know how to reduce the risk in your organization or for your team, there's a lot of information on our website. These are the references. They come mainly from the Guiding Principles by Johns Hopkins, and it's one of the most credible public health organizations. And that will lead us to the next section of the meeting, which is questions. And again, I managed to go over 5 minutes or so over my time. Apologies, Drew.
Thank you very much, Dr. Era. I'm going to lead off with questions on recovery. We have quite a few of those, and really, if you can expand on what does recovery look like, and on the opposite of that, what are the jeopardies, what are the triggers that would move us backwards in this reopening process?
So recovery is exactly what I presented about the different stages of reopening, and we have been successful in the recovery in Grey Bruce to maintain control over the outbreak, where we saw sporadic cases, but not outbreaks. And that would be my assessment going forward into school reopening. There are two main factors in the recovery in this case: school reopening itself and the cooler weather that would come with it. Both factors might change the dynamic of the outbreak. However, I have full confidence that the public has been engaged, has been doing the right thing. I see no reason why this would not continue forward. And again, the recovery would end in one of two cases. One, if they have the vaccine. And the second one is if we didn't find the vaccine, is to actually have herd immunity through the number of people infected. When we reach the 70%, that's where the virus would not be circulating anymore. Nevertheless, I'm cautiously optimistic this will happen through a vaccine, like I mentioned.
I'll move forward to a question. You touched on schools. How will the school reopenings work in Grey Bruce, I guess, is the general question I've got here on the chat line.
Certainly. So that slide about who makes the decision is really directly related to this one. There is provincial direction for how to open schools, and to my delight, it's very consistent with science. Each school has been asked to have 3 plans: one for complete shutdown and work remotely, one for complete traditional return, all kids in school, and one modified in the middle, where there are 50% of the kids in each class, and they take alternate times, whether it's morning, afternoon class, or based on days of the week. We are in Grey Bruce in a relatively positive position where we can go traditional in all age groups. And these direction that comes from the ministry, they're going to be updated continuously. Like we saw a few weeks ago, having the direction to all schools to have 3 plans. Now it seems the traditional plan will be applicable to almost all kids under a certain age, grade 3, and over age 3, it might be modified or traditional, depending. Those things will change, and rightly so will change. And we will get to a point in September when we reopen schools. If we have the same epidemiology we have currently, I'm confident we can allow our kids the opportunity, or we, all of us have worked really hard to allow our kids to have the opportunity to interact socially and to have their learning and to have full return with full number of kids. We will continue in all cases to monitor, and switching between these plans is not unexpected if there is a change in the dynamic of the outbreak. And we'll learn a bit more about it as soon as we know which age group is more susceptible to infection and transmission, acquisition and transmission, two terms you would probably hear a lot going forward. There are some studies coming out that kids under 10, they're not as transmissible. Then there are certain other studies, they would say their viral load is really high. And until we see how it's going to work out, all these things are theoretical until we have the ability to control it. Nevertheless, the same principle, we don't really take risk with these things. We take the conservative approach until proven otherwise, and we move gradually.
A follow-up question asks, what would happen in a classroom with a positive in a child? What would happen in that classroom setting? Would the classroom be considered close contacts?
I hate to answer with the word depending, but it's actually, the situation is very, very complex when you deal with risk of transmission in almost every scenario. However, in schools, it's even more complex. It depends on the age of the class students, and depends on the type of activity they have, depends on the time, the length of time that person who was diagnosed has spent with these people, and depends on how infectious they were. And when you put these variables in each scenario, we study it one by one, and we make these decisions at the time. If the person, was sick and didn't attend school more than a couple hours in the past few days, really there isn't much risk other than you ask these people who were exposed to self-monitor if they are older kids and they know they didn't, spend time touching each other like little kids, versus a scenario where it's a daycare or close to daycare age, and these kids touch everything, and everybody will be considered close contact. And again, these risk assessments are done case by case and done through robust protocols, the same protocols we used so far, and we have the proof of having zero transmission to any coworker in a workplace, or zero transmission to close contacts other than spouse or very close contact, somebody's taking care of their family member. There hasn't been transmission in Gray and Bruce after any case that we investigated and dealt with.
I'm going to move into a question with regard to the workplace and business and office settings. A number of places have some sort of level of screening or asking employees how they're feeling, and if an answer is positive to a screening question, or presenting with a cold or flu-like or an allergy symptoms, should these people stay home, or what should they simply do?
As soon as somebody has these symptoms, they should not go to work. They should seek health care. They should call their physician or nurse practitioner, and depending on the assessment of that healthcare provider, they might get tested or isolate until the symptoms are gone. If the assessment reveals that the symptoms are not related to COVID, could be cough related to asthma, the person can go back to work. However, these assessments need to happen before making a decision. As employer, as a manager in a municipality, the goal would be to have screening available for these employees, and as soon as one individual is identified as positive on the screen, is to ask them to go seek that care and isolate until they get the assessment. Drew, you are on mute, sorry.
The question is, what is the plan for reopening of county buildings? Can you address that?
So that would come from the county, not from myself. However, I know that they have had all the resources to have a plan that is robust and safe. And if you look at the risk in a county building, it's very similar to the risk in a health unit where we work. And we've been working nonstop since the situation started with zero transmission within the health unit. And the plans, I suspect, for the county would have the same measures that we have in the health unit. It is on our website, and the county consulted with us on different aspects of it. Again, how it would look like, it will come from the county, not from myself.
I'm going to double back on a question in the chat with regard to children, and the question has been, what has been the case with regard to positives in children in Grey Bruce? Have we had many?
We had quite a few, and all ages. We had as young as 2 months, and there was, I believe, 5 months, and I believe 2 years. You know, kids are not immune. They get the disease. They tend to have almost asymptomatic disease, minimal symptoms, more or less. And the stats from China, the stats from the world right now, all of it says they're not immune. They can get the disease. However, their risk of complications or severe disease is very low comparing to other age groups.
I'm going to move into another area with regard to seasonal residents in the area. Some might be choosing to self-isolate here. If they have tested positive and reporting back to their home health unit, is the Grey Bruce Health Unit aware of their presence here in the area?
Yes, we are, and we usually work with the other health unit to monitor them. We take the lead in monitoring them since they are our area, and we definitely call them every day, and depending on the level of compliance, sometimes we do a door knock if compliance is an issue. Though we had a handful of these cases, and they're not different from any other case. The risk to any individual in Grey Bruce is similar. If there is a person isolating in Toronto or isolating in the room next to me, my risk is the same. It's next to nothing. If there is a wall and a different room, that's, again, there is no risk for the public. And from that point of view, if you look at how many visitors come to isolate here or how many cases from Grey Bruce isolate somewhere else, really it's not changing the risk to any other individual in the community. It shouldn't be really a concern.
Following up on that, how does an active case become inactive? Does someone need a negative test to be deemed inactive?
That's a good question. Sometimes it requires a negative test, and if it's a healthcare worker going back to work, we used to actually do 2 negative tests with 24 hours in between. By definition, the lab will take a bit more than that. In general, it's 14 days since the symptom starts, if there are no symptoms. So let me rephrase that. That a bit might be confusing. Since the start of the symptoms, we will count 14 days. That's the end of the isolation where the person is considered recovered, or longer if there are more symptoms. So if there are symptoms at day 14, they will continue until 48 hours without symptoms. So 14 days or 48 hours after symptoms if longer than 14 days.
There's been a lot of discussion about masks, so we'll go to that topic now. The first question, and sort of leads into the second question, why masks now and why not earlier? And then for how long can we expect the wearing of masks in public to be in effect in our area?
Masks, for some reason, become very important subject, although, you know, physical distancing is way more effective. Nevertheless, the evidence on masks didn't change. If mask use in pandemic and public places is part of the pandemic plan, and that has always been there. There should be criteria in place for it to be implemented. To pull the trigger on this public health intervention, to mandate it or to strongly recommend it, there should be set of criteria. The main 2 criteria are the presence of community spread and the presence of interaction among people. So if you go concretely and look in January and February, I spoke to the Board of Health and the 2 counties And we advise that we need to dust off our pandemic plans. This is coming, no question. There is no need to implement masks at that time because there is no community spread. It will be futile for any person to wear a mask at that time. Then we go forward in time to March and April. There was community spread, but there was no interaction among people. Most of us were in physical distancing completely, shut down completely. So again, it will be futile for any person to sit on their couch alone in their home wearing a mask. Wearing a mask in public as intervention becomes effective in the reopening stages. If the first stage or second stage where the risk is low, but there was enough cases, the epidemiology suggested that there is active outbreak, it could be appropriate to implement it there. In Grey Bruce, we didn't have that. We had low number of cases, full control of the outbreak, so there is no need to pull the trigger on it. The longer you leave the intervention, the better it would be. We need to pull the trigger on this intervention at the time that is most useful, because the length of time where people would actually not be fatigued by it, the length of time you can maintain it is limited. Like we know in April, we shut everything down. By May, by end of June, people are sick and tired, fatigued of physical distancing and staying at home, and fatigued of what the messaging about it. So similarly with masks, if we implement it in May, by now, we are going to find some of the public being fatigued of it. And if we go into a second wave, again, at that time we need it, but we're already fatigued of it. So holding back until the third stage, where the highest risk there is, would be the appropriate time to pull the trigger on it. And that's why it is now. And again, without enforcement, we have seen buy-in from the public, or each person who's saying, I don't want masks. There are 10s or 20 people who are saying, thank you, but why didn't you do it with enforcement? Or why didn't you issue it a stricter situation without exemptions? And that takes me to this last part about this subject. The order from the MOH is in place only for 1 month, with potential renewal of a second month. And the goal of it is to buy time for the municipalities to have a bylaw. A bylaw is the appropriate vehicle, legal vehicle, to mandate masks. The MOH order is in place because it's just, you can do it overnight based on consultation with everybody around the table. It's never a one-person decision. How long would it stay in place? I suspect it will stay in place until we have the vaccine. The order itself will be rescinded maybe mid-September, when if the municipalities decide, if the council decided to pass a bylaw. And currently I am working with both municipalities, with both counties, to pass or to work on potentially passing a bylaw. If we go into the fall and there is a second wave, mandating it with enforcement, again, depending on the level of compliance from the public and the fatigue of it, how long it will last, again, until a vaccine is in place, or if we get to a stage where herd immunity was achieved in any other way.
A follow-up question to that is staff working on front counters. If there's a plexiglass barrier and the public is coming to the counter wearing a mask, does the employee have to wear a mask?
So if there is a barrier that extends close to the ceiling, and there wasn't direction early when we mandated the masks, so we mentioned that it has to go all the way to the ceiling. Later, there are documents coming from different ministries. If it is 7 feet, which is 1 foot over the tallest person, that will be sufficient. And if it's wide enough, of course. But if it's not, if it's one of these shields that you would see in a grocery store, 1 meter by 1 meter or something to that effect, a mask would not be, a mask would be needed, because that shield is not going to protect from droplets going around.
I'm going to move to a question with regard to COVID-19 itself. And can you speak to the false positive results and what are they all about? What do they mean?
Certainly, that's one of the rabbit hole for resources situation that we have. So any test is validated based on criteria to apply the test. The COVID diagnostic test is validated for people who have symptoms or had been exposed to a case. So if you test people who are not symptomatic and they were not exposed close contact to a case, you're really rolling dice because the test loses its predictive value, technical term, positive predictive value and negative predictive value, more or less the reliability of the test. So we saw that there was a phenomenon, to the best, this is my own bias, Ian's bias, the public has been led to believe that testing is a silver bullet and we need to offer it to everybody. And I believe that was done through big media outlets, putting that pressure on the government through the media. And there was, at some point, there were many questions from the public, is there testing capacity? And when you lose the trust of the public or close to losing the trust of the public, that's really a big issue. And in the middle of emergency is not a good situation. So to show capacity, more or less, there was testing of asymptomatic people in nursing homes. Everybody will be tested. Scientifically, it's not going to change the management of the outbreak because we depend on identifying a case based on symptoms. We trust the test and we follow up and we nip it in the bud. It wouldn't go to an outbreak. So when we tested 3,000 people in Gray and Bruce, we found 9 people to be positive. All of them, 5 people to be positive, all of them proven to be false positive. And the false positive is when we get that result from people without symptoms and we cannot trust that result, we do a few things. One of them is to test the same sample that was tested first. Usually it's frozen in a lab. So we ask the lab to run the test again, concentrated test. And we test the same patient 2 more times right after. So we have 3 more results coming back. Universally in these 5 cases, it came back as negative. So if you can imagine a pregnancy test in a woman who lives on an island of women, like you can't trust that test because that person cannot be pregnant. And similarly, if you get a positive in a patient who lives in a nursing home and nobody else in that nursing home, not a patient, not a resident, not staff, all of them are negative. How did this person get the disease? So that's why we repeat the test and we prove it is false positive. Again, the test is very robust, actually highly sensitive and specific when it's used appropriately where it needs to. And that's why I would advise people around the table, this is practical advice. If you don't have symptoms and you just think that I want to go get tested because I ate in a restaurant and that there was a case there, that's not a good scenario because you could test positive and you're really not positive. So again, follow public health advice. You'll get the call if you're exposed. Anyways, that was a bit detour from the question, Drew.
Well, a little bit related to that is if someone is a carrier of COVID-19, how long can they stay as a carrier?
So that's a question that I can think of the word carrier to mean 2 things. In medicine, carrier means they carry the virus, but without any symptoms, without infection. And it's different from asymptomatic. But anyways, if they meant asymptomatic, usually it's 14 days. That's a very conservative estimate. I needed to mention that before. There's evidence that 10 days are sufficient. A person is not infectious after 10 days, however, 14 days. So if a person was exposed and they're carrying it and they never got sick, in 14 days, they should be not shedding the virus. This will change if the person is a young kid or a person who has weak immunity, immunocompromised patients. That period could extend to 21 days. I can think of the other alternative of carrier is if a person is asymptomatic and shedding the virus. And again, that will be the same number, 14 14 days.
Thank you. One area we haven't touched on is, and there's a question related to it, is return to play and how communities are attempting to reopen community centers, arenas, etc. Now, how will that process move forward? And also a sort of an aligning question is, how will that work with visiting teams from other health unit communities or other health unit jurisdictions? So when two health units cross over in terms of the participation.
So from a risk point of view, these activities carry risk. And again, the lower the number of people in a sport, the less risk there is. The interaction with other teams would carry more risk. From regulation point of view, probably I should turn it to Andrew. He's taking the lead on answering these questions related to organized sports.
Thank you, Dr. Ara. Yeah, so obviously team sports are now allowed with the stage 3 reopening regulations. However, there are still quite a few restrictions in place, both on the types of sports that are permitted. They've not been named by the sport, but the sport activities that are permitted are those that either don't have or can be modified to not have high level of physical contact. So as an example of something that can be successfully modified, we've seen is something like baseball or softball. The government used the example of wrestling as something that they would imagine would not be permitted. I think the difficulty perhaps is in those grey area sports that are somewhere between those two extreme examples, so things like soccer and hockey. And we're still really waiting for a lot of those kind of provincial organisations to come forward as to see how they might be successfully modified. The other component to that is the numbers, and with the regulations at the moment, they permit a maximum of 50 for either a league, or if your league has more than 50 individual players in it, which would be the case in most cases, the league would then have to sort of subdivide into groups or cohorts of 50. You can imagine perhaps 3 or 4 teams within that group playing each other. But then you wouldn't be able to have teams from the one group playing against teams from the other group. So to directly answer the question, to have teams from a different area playing a team from, Walkton, for sake of argument, they would have to be part of that same group of 50. And I think in most cases, you're probably going to see those groups being more localized and perhaps less of that inter-regional travel. All of that is based on current regulations, of course, which could change.
I'm going to ask one more question related to that, Andrew. They're asking about parents, people in the stands.
Right. So there's actually quite a bit of language in the regulations about sports facilities, and part of that is talks to spectators. So there's actually a separate number, a separate 50 or maximum 50 for inside, 100 for outside, that's allowed for spectators. Now I should say that these are a cap, of course. So if you have a small facility where you can't safely physically isolate, then doesn't mean you can go ahead with the full 50. But assuming you've got a fairly large facility where physical separation is not a problem, then you could have the actual sports activity going on with the various people, and then you could have 50 spectators. And in fact, you may have a separate area within that same building that has a weight room, a sort of traditional gymnasium, traditional gym, where you have an additional number on top of that. So what I would say is this gets quite complex, and if there's individual facilities trying to work out, well, what does this look like for them, it's probably best dealt with on a case by case, and we have staff that can help people through that.
Thank you very much, Andrew. Appreciate that. We're getting down to the end, but a couple more questions in the chat room. I'm going to ask Dr. Ara. There's one with regard to asymptomatic people in the area, but they haven't been tested. They're just out there. We have no idea of how many there really are, and how will their presence affect openings and the recovery, and perhaps even with the schools bringing more people together, will we see an increase in cases?
That's a really good question. And as we all know, early in the outbreak in a pandemic, there was evidence of asymptomatic cases, and that was a game changer. Later, around May, June, there was evidence that came out of CDC Atlanta Center of Disease Control, one of the most credible public health organizations. It's the most credible in the world. They clearly proved that asymptomatic people are not the driver of the outbreak. So they exist, no question, they exist. However, they do not change the dynamic of the outbreak. And that's practically, if you can think about it, if I am asymptomatic and I'm shedding the virus, that's good and dandy. I'm not going to be tested unless I have symptoms. But by definition, if I'm shedding the virus, my daughter or my wife is going to be coughing in a couple of days. And that's where public health protocols will test that person who's coughing and go test their family members, close contacts. So whether I am asymptomatic, shedding the virus or not, I will be caught through the system. Are there asymptomatic in Grey Bruce? I have no doubt there are. I have no doubt there are symptomatic people who are not tested. Not many people, not every person who have symptoms run to the assessment center to be tested to do the right thing. The estimate in general for each case we found, there are 2 to 10 cases we didn't find. In our area, with the level of testing that we have and the communication we have, I would say for each case, there are at least 3, 4, maybe 5 cases we've not found because they really never got tested and they recovered at the end of the day. So when you look at the epidemiological curve and the way it shapes, if you test everybody in a community, that curve is going to be bigger. However, it's going to take the same shape. So since it's tapered off, I have no doubt we had more cases out there that were not caught. However, this number is going down because the number that we see is going down. So it's a proxy to what's going on out there. The goal is not to catch every single case. The only way to do it is actually to test everybody in the population 3-4 times to rule out the false positive and find them. However, we can manage the outbreak without finding every single case. And we have been very successful doing so. So back to the question, are there asymptomatic? Probably yes. Are they a driver of the outbreak? They're not. There's evidence they're not to be considered a driver of the outbreak. And we can eventually find them through the people who will get sick by contacting them, and will be tested, and we'll do the tracing backward.
Well, Dr. Ara, I'm cognizant of the time. I would say thank you very much, and thank you everyone for joining us on this Zoom event. As I stated at the outset, this has been recorded and will be posted on our YouTube channel. Any additional or unanswered questions can be put to us through our Contact Us page on our website, and I do encourage you to visit our website frequently. Information is updated, and there's a lot of support resources available for you. And responding to your inquiries, the email is publichealth@publichealthgraybruce.on.ca. Before we close, I want to thank Bruce County for bringing together the participants in this session. Thanks to Sandra for facilitating. And with that, a final thank you for your participation today.
Thank you all. Stay well.